Thank you so much, Dr. Amol, for involving me in this lecture. And it's always difficult to speak after Shubham Garg because he's very precise and he gives an excellent talk each time he comes on stage. So this is a surgeon's perspective on role of SBRT in early stage lung cancer. Not writing off SBRT altogether, but you'll see the reasons why. Can you see my slides?
Yes, sir. You can see yours.
Yeah. So early stage lung cancer, around 16% of NSCLC patients present in early stage, and of that only 2/3 can tolerate a lobectomy. So you listen to Dr. Garg speaking on sublobar and wedge resections and their outcomes compared to a lobectomy, but still lobectomies are considered the gold standard for lung cancer surgery, however early the tumor is, if the patient can tolerate it. SBRT is slowly becoming popular in the management, especially after its success in medically inoperable patients. Now we'd like to understand what actually SBRT is. So, SBRT is radiation that is delivered at a very high dose per fraction, and it is usually between 45 to 60 gray in total in either between 1 to 5 fractions. Highly conformal radiation. So normal radiation, you go at 4 or 6 angles when you treat tumors with the regular radiation techniques, but with SBRT, they go even up to 60 to 100 so that you get a conformal radiation dose. And it accounts in the case of lung for movement of the tumor as well during respiration. So it's a little complicated than the regular type of radiation that we usually give for other cancers. And it involves a very high biological equivalent dose of more than 100. So how did this SBRT come to the picture in non-small cell lung cancer? Like in almost all cases of cancer management, they worked their way from below upwards. So you look at the first signs of any usefulness came when you compare the conventional type of radiation which was given in medically inoperable patients of cancer versus SBRT. So when they compared SBRT versus a conventional type of radiation in patients who could not be operated because of comorbids or other factors, you can see the 5-year overall survival over here was 10% versus 56% 3-year overall survival. Almost you could say a 3 to 4-fold increase in survival for a patient who could not be offered surgery when you compare the regular type of radiation versus SBRT. So this proved the way for SBRT to enter into surgical practice of lung cancer management. So you had this backed up by various kind of retrospective as well as prospective studies, and there's no question that in a medically inoperable patient that radiation plays a role. Now what happens? How did they enter the field of medically operable patients? So you had two small studies, multi-center but cooperative group studies, which were performed in Japan as well as the United States and North America. You can see the low number of patients that were used because it's very difficult to get these patients accrued on a study because of the dominance of surgeons in lung cancer. And you can see they had operable criteria as FEV1 of 800 milliliters and arterial PA pressure of O2 of more than 65 as a contraindication for a surgical candidate. And patient had no severe cardiac morbidity or severe diabetes. So these were typically operable candidates who went on to receive SBRT. And they found that there was a 3-year overall survival and local control of 77% of overall survival and a local control of 87% in the Japanese study when they gave SBRT in early stage lung cancer. And the SBRT arm had no grade 4 or grade 5 toxicities, whereas the surgery arm, and this is another study from North America, which had 26 patients giving 54 gray in 3 fractions. And they also reported a 2-year local control rate of as high as 92% versus an OS of 84%. So these are very good results for patients who are operable as well. But the real challenge came when this paper was published in the Lancet by Chang and Professor Senan. So actually this was a randomized phase 3 study which was initiated by the STARS group as well as the Rosal group. The STARS group, it was done in the US, and the Rosal group, which was from the Netherlands, they wanted to accrue about 100 plus patients on each direction, but both of them landed up together accruing only about 58 patients. And their graphs were as follows. So this is the OS graph, and this is showing you that the 3-year overall survival is higher in SBRT, which is shown in blue, 95% versus, surgery, which is 79%. And this is a recurrence-free survival, which is also, was not significant, but it was found to be, better in the SBRT group versus the surgery arm. And this was actually from a study which stopped accruing because they couldn't get patients to accrue, and only 58 patients. So both these studies had to combine their results to get a publication. But look at the conclusions. So this is the conclusion. SBRT is better tolerated and might lead to better overall survival than surgery for operable clinical stage 1 NSCLC. These findings suggest justify a large randomized trial to investigate the superiority of SABR or SBRT. And physicians should interpret these findings as at least clinical equipoise between SABR and surgical options, and should consider SABR as an option for treatment for all stage lung cancer. Now, I fail to agree to this because you can see that just with 58 patients, completely, turning the tides over a modality to another modality is actually very difficult. Now, why does this kind of a paper cause so much confusion? You can see, like in our country, 5% of our cases of NSCLC come in early stages. There's very much less expertise in surgical management of lung cancer, even in most states. More than 80% will choose a non-surgical modality if they are given a choice. So I'm sure that most surgeons in this group and most oncologists, if you give a choice for a patient and tell them that, there's an option where you don't need surgery, whereas there is an option where you need surgery, you know what our Indian patients are going to choose. And this is being portrayed as a filling of the gap scenario. So SBRT is trying to fill this gap of this need for a non-operative curative modality for lung cancer. But our question is it right to go for with a conclusion like the above study? And is it safe in the long term for patients? So this comes to the picture of a surgeon's perspective. When we come across a patient of lung cancer, we assess them both staging wise as well as physically. So when we do a physical assessment, we use pulmonary function test as a guide. So these are standard guidelines in which if these criteria are not satisfied, they will go on to be termed as medically inoperable, and they will not go on for surgery. So you have FEV1, DLCO of less than 40 to 50% predicted as a contraindication for surgery. You have a PaCO2 of more than 45 to 50 as a contraindication to surgery, and so on and so forth. So what's actually wrong with surgery? So surgeons like us need to retrospect and see, why are people choosing SBRT over us and the world over? So there are certain pros with surgery. It provides histology compared to SBRT because most of the patients many patients in the previously mentioned randomized trial of SBRT versus surgery, they did not have a biopsy. Surgery provides histology for a patient, which can help in further treatment of the patient. Accurate staging is possible because most surgeons in this panel, I'm sure, are convinced of the role of lymphadenectomy in performing after lung cancer resection. Those who are upstaged actually receive some form of adjuvant treatment in the form of radiation or chemotherapy or both. It improves overall survival when we do when we know for sure that a lobectomy improves overall survival, as mentioned by the previous speaker. And follow-up is relatively straightforward. You need to do scans on a regular basis to identify tumors. What are the cons? There is an issue of pain with open thoracotomy. Even with VATS, you have a certain amount of pain the patient has to bear. There is definitely a decrease in pulmonary function to the tune of about 30% FEV1 at 3 months, which improves to 10% at 1 year. And sometimes, especially in a country like India, surgery is technically demanding, especially in our country where we have a lot of adhesions, bullae, previous surgeries, and TB. with inflammatory lesions predominating in our country, surgery sometimes may be difficult. And mortality is definitely a reality. You have from the worst of a 14% to as low as 1% in high volume centers. And you must be careful, especially in operating the patients who are elderly and who have multiple comorbid conditions, because mortality in this group is higher. But I'd like people to just note this study. By performing surgery in a patient who especially is having a bad lung or a poor postoperative predicted FEV1, you can actually see that there is an improvement or a decrement compared to the preoperative situation. This happens classically, especially in a country like India, because many of our patients with upper lobe cancers are usually in smokers and they have severe emphysema, and a lobectomy actually acts as a lung volume reduction in these patients. And you can see that by just performing a lobectomy, the poor FEV1, which was seen prior to surgery, actually improved in the postoperative period. So surgery is beneficial in high risk, and what we term as inoperable medically in the previously mentioned criteria actually must be looked greater in detail. And you can see that expert surgeons can get better results in high risk patients because lung volume reduction and cancer go hand in hand in making the patient improve clinically. Then there comes the role of VATS and MIS approach. There is a less decrease in FEV1 drop. There are comparable oncological outcomes compared to open thoracotomy. And this may be an important factor to tilt the balance of high mortality following thoracotomy in patients who are high risk and with comorbid conditions. You have excellent papers to mention about this. A lot of papers talk about this, that when you, and currently most surgeons who have a focus on lung cancer are performing these procedures, either VATS or robotic, using minimal access approach. And definitely, papers are there to suggest that the outcomes are better. The mortality is lower. What is the role of sublobar resections? Now, lobectomy is not the only requirement. You saw our previous speaker mention about the role of segmentectomy and anatomical segmentectomy. So this is actually an anatomical resection where you go up to the tertiary level bronchi, go up to the root on the insertion into the major bronchus, take lymph nodes along with you. So lymphadenectomy is part of a segmental resection. There are better margins in this surgery because it is mandatory that you achieve at least a 1 tumor diameter margin on each side in all dimensions, 3-dimensional as well, when you're performing this surgery. And there are various studies to prove that FEV1 drop is lower when you perform an anatomical segmentectomy compared to a lobectomy. So actually, there are many studies which prove, I'll come to a slide in the next slide, that in tumors less than 3 centimeters in size, segmentomy may actually be equal to a lobectomy, and those patients can be offered a segmentectomy. In this study, published just this year, last year, 2020, although lobectomy is the gold standard, they found that this is a group of patients where they found they compared the role of lobectomy in a single center versus, and they found that for tumors more than 3 centimeters in size, there was a separation in long-term overall survival benefit when you do a lobectomy. But the same thing did not hold good when it was the lines almost were similar when you compared segmentectomy in a patient with a tumor less than 3 centimeters in size.
We can't hear you, Saravana.
Saravana, we can't hear you.
Am I audible now?
Yeah.
Audible.
Yeah.
So radiation oncologists and surgeons actually define local recurrence differently. As surgeons, if there is recurrence in the same lobe, we term it as local recurrence. If it's in another lobe in the same lung, we still term it as local recurrence. And if there's ipsilateral nodal recurrence, we still term it as a local recurrence. Whereas you see most SBRT studies, they do not mention these two as local recurrence. So they actually, when you compare oncologically, this can never be an equivalent to surgery. And actually the only thing is progression at site of tumor or radiated area in the particular lobe is the only indication to be termed as a local recurrence in SBRT studies. So this is a major point that needs to be understood, and for decision making for oncologists as a whole, because these terminologies create a huge confusion among clinicians. So complications, like I said, in surgery, we do have mortality, especially in higher risk and elderly patients, whereas SBRT is not without complications. You have the incidence of radiation pneumonitis sometimes to the, in some randomized trials as high as 38%. There's no consensus regarding the criteria for radiation pneumonitis as a standard. So, I'm sure many of us in our practice would have seen patients with SBRT having radiation pneumonitis as well. A lot of patients had been reported earlier to have ribs fractures, but these typically occur to the range of 4% and in tumors which are large and near the chest wall. And when you give high dose of radiation, a BED dose of about 100, you tend to develop rib fractures in those regions. There is also an FEV1 drop when you do SBRT to patients. And like you said, there is a 7.9% drop at 21 months. Like I said, in surgery, the maximum drop is at 3 months, which stabilizes to around 12 months. So this FEV1 drop should not be calculated 3 months post procedure, but actually should be calculated at 21 months. So PFT drops in SBRT are also an important factor which need to be seen. And there is a mortality of about 1 to 3% that is mentioned in population data. Now, what happens in the real world? This is an excellent study which compared American data from the National Cancer Database. And what it studied was they took all cases which underwent of stage 1 lung and non-small cell lung cancer in the United States, which were entered into the database, and those who received surgery were compared with SBRT. And these were patients which were matched, and only patients who had a Charleston Morbidity Index score, it was propensity match for CMI score along the borders. Patients who are medically inoperable were excluded. And you can see in real world, though many more patients are undergoing SBRT
Saravana, you need
nowadays.
to wrap up early.
Yeah, these are three more slides, that's all. So you can see a wide difference in SBRT versus surgery, with surgery doing better. And what about sublobar resections versus SBRT? When you look at long-term survival, SBRT is inferior to sublobar resections when you take long-term data into concern. This is OS data from about 26,000 sublobar resections and 6,000 SBRTs. So what studies do we have now? We have 3 randomized trials which had stopped accrual, closed due to stop accrual from Northern America and Europe. And we have many more studies which are ongoing and results are expected. And when you look at all these data and look at studies, you can see that surgery clearly wins head to head with SBRT when you look at medically operable patients. So I would like to suffice with this. Most lung cancer patients need to be treated in a multidisciplinary tumor board. There is a need for biopsy prior to surgery for stratification and treatment assessment. All patients need to be adequately staged with the PET and mediastinal staging using EBUS or a mediastinoscopy. Option for sublobar resection can be offered for patients with stage 1A tumors at the present. Risks for surgery should be assessed differently because you should look at emphysema and not just look at numbers. There are other options available also, like RFA and targeted treatment that are coming. So this is my last slide. So as a surgeon, what do I feel are the role of SBRT in NSCLC? I think for a medically inoperable, there's no question. There's a level 1 evidence, and we should consider patients for the SBRT in this scenario. In medically operable patients, only those patients who are refusing surgery adamantly, those who are high risk with comorbidity status in view, those who have had previous lung resection, because in my practice as well, I am seeing a lot of patients who have undergone previous lobectomies now coming up with small lesions in the same side or the opposite side, metacranial lesions, which undertaking a lobectomy in an elderly patient again would be difficult. Those cases are ideally suited for NSCLC, for SBRT, and accurate staging and histology must be done in cases. Even if you're going for SBRT, I insist on most patients considering SBRT to undergo an EBUS and a tissue diagnosis of the primary as well. And there is data to prove that SBRT is also similar to surgery, that in high volume centers, the results are better compared to low volume centers. So to avoid SBRT, even in patients who are medically inoperable, those who have central tumors size greater than 3 centimeters and tumors in other chest wall, I think this has given a good idea of the role of SBRT in a surgeon's perspective. Thank you, Amol, again for the opportunity, and we'll take questions later.
Yeah, thanks, Saravana, for the nice lecture. We'll be taking questions for both Dr. Saravana and Dr. Shubham in the panel discussion, because Dr. Prashant has